third degree heart block. Let's go into a third degree heart block.
Is it still? Oh no.
So a third degree heart block.
There's only one type.
They always keep leaving or what?
Watch.
Wait, hold up.
Heart block. Put the numbers, third degree heart block. At this point, look at the P waves. They're about within good range. You guys see that? P waves within themselves, they're within good range.
Mm-hmm.
So that means that the SA node is firing off good. But look at the QRSs. They have no pattern whatsoever. There's no correlation. The QRSs are doing their own thing. So the ventricles are firing out by themselves, and the P waves are doing their own thing. So the QRSs, they have their own pattern. You see that? Like within the same width. My finger length, same width, about the same width. See that? The QRSs. But there's no relationship between the P wave and the QRS. At this point, they just gave up and they're doing their own thing. The QRS is going out doing their own thing, and the P waves are like, I'm not even thinking about the QRS anymore. P waves looking for a new QRS, and the QRS is looking for new P waves.
That's crazy.
It's a complete disassociation between the atriums and the ventricles. Does that make sense? All right. Any questions about that? So at this point, this patient would definitely need what's called a pacemaker. For sure. And the pacemaker is gonna put them back in sync. Remember that video, the guy that he said that they're gonna do what I want because I have a gun? That's the pacemaker is like the man with the gun making them do, all right, you're gonna go, then you're gonna go. You're gonna go, then you're gonna go. So all the pacemaker is, to get a little bit deeper, a pacemaker is, we guys have seen a pacemaker kind of? Somebody who's seen a video, like it's like a little, like hump, there's like a little bump on here. It's as literally like a little battery device they put under your skin.
When we did the CPR class with McCullough, he said that if somebody has one of those, we can't put it on there, right?
Perfect, yes,
Okay.
that's what we're talking about.
Okay, yeah.
Okay, so from that device, there's wires that come out. So that's one of my jobs back in the day, was helping the cardiologists put those in the patients. And those wires, those wires usually come in through the superior vena cava, this way, that vessel that dumps blood into the right atrium. And what they'll do is they'll just figure out, it depends on where it has to go actually. They'll literally, let's say if the problem is down here, they'll literally put a wire in here, and they literally screw it in. They screw it in, and then they screw it in, and they'll get another wire, and they'll put it in here, and they'll screw it in the top, and then all they do is they just set an algorithm. So, and the algorithm is as simple as when the atrium space, then a few seconds after, let's say 0.12 seconds after, we're gonna make sure the ventricle space. Bam, 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 and it does exactly what the conduction system would do. But now the conduction system is gone. So now we have to do it like with a little mini robot, I guess. That's one way to say it.
So if somebody with a third degree heart block doesn't have a pacemaker, they die?
They could potentially die if they don't get one fast enough.
So if
they're gonna need one. They're gonna need a pacemaker to stay alive longer.
Okay, and let's say you're doing CPR to somebody and you put the AED on the pacemaker, and the electricity is shot through the pacemaker and it's directly to the heart. Wouldn't in theory that kill the patient?
It could theoretically it could fry the pacemaker, and then you should lose your job. Because you were trained a certain way.
Right.
Yeah. So the way it could kill a patient is because it sends a lot of electricity between the pads, and you could fry the pacemaker. And then that pacemaker costs a lot of money as well. So like, because can that patient afford that? You know? So there's a whole lot of things that go into that. But yeah, technically you could kill the patient down the road, or even within a few minutes. Because even if you brought that patient back to life, it could have been because the pacemaker glitched out. So one thing about the pacemakers, you guys should know, is that a big, strong magnet can throw it off of its normal algorithm.
Mm-hmm.
So if let's say I'm working somewhere by a big device and I don't know what's in this device, and there's a big old magnet, it could throw my pacemaker into a rhythm that's not normal, and I could pass out and then go into cardiac arrest. But once I'm away from it and I got shocked, then I could come back and kick back in. It was just temporary. It was just temporarily disarmed because of whatever I was next to, a big old magnet or something. Because other things it's a device like any other device. Yeah. Also, one thing we tell, because I used to teach. That's why I know about this. Because I used to teach the cardiologists and the patients when they got it. Another thing is we tell them if they're a welder, don't weld no more. Because even the electricity and all that power can throw your heart. It can make it seem like it's going through ventricular fibrillation, because all the and then it'll just shock you out of nowhere because it thinks you're going through a dysrhythmia, but really you're just over here just welding or whatever. So certain things can throw it off, but once you're away from that, the pacemaker can go back into its normal. So you want to make sure you don't mess with that.